Hello guys, today we start talking about wound healing, and today for us is important to understand this topic because the wound healing will explain you absolutely all topics everywhere in every pathology. It is the most often pathogenesis what happened in our organism. Wound. Skin wound is a result from the breakdown of the epidermal layer integrity. Any tissue injury with anatomical integrity disruption with functional loss can be described as a wound. Wound healing mostly means healing of the skin. The wound healing begins immediately after an injury to the epidermal layer and might take years. This dynamic process includes the highly organized cellular, humoral, and molecular mechanisms. Phases. Wound healing has three overlapping phases, which are inflammation, proliferation, and remodeling. There in the slide you see that I have one more phase, hemostasis. We have few classification, and mm, in one classification we have 4 stages. In the next classification we have 3 stages. There you see the selection where I tell about 3 stages, but I will often remember you that stage hemostasis, what are in Russian classification like first stage, um, is a part of the stage inflammation. Yeah, and hemostasis, it is a step of bleeding. Yeah, and there you see day 1 to 3. But of course, if hemostasis happened just in the third day, it will be bad for our patient. Yeah. Inflammation start from the third day and finished on the 20th day. But I don't agree with this picture because I think that inflammation start at the first day and finished in the 12th day, 20th day. Proliferation or granulation, first week to 6th week, and remodeling or maturation from the 6th week to the 2 years. Any disruption lead to abnormal wound healing. Healing or intention. Wound healing is occasionally classified as primary healing or intention and secondary healing or intention. In Russia, we talk about the third one, tertiary intention. When we talk about primary intention, how you seen, we have the incision, it is clean, we do the sutures, and we see the a little line. Yeah. When we talk about secondary intention, we talk about deep wound, grabbing irregular wound. We see that in all tissue we have a granulation. Yeah, and after finished of granulation, we will have epithelium growth over scar. When we talk about tertiary intention, we talk about non-deep wound. Yeah, you see that the layer is not so deep. More often it is a second or third layer of the skin, and how you see there, we have a wound, not deep, yeah, and all this wound will be with granulation. And maybe after it we can do the late suturing, but more often we never do the second suturing there because it's not important for us. More often tertiary intention, it's like when you do a forgot, I need 1 second. It's often when you do dermabrasion, dermabrasion of your skin. Yeah, for example, you fell out and you see the small wound without deep wound. Yeah, it is dermabrasion, how you remember in the last lecture. And the tertiary intention more often happened with this one. Primary healing, uncomplicated healing of a non-infected, well-approximated wound is defined as primary healing. Surgical wounds are the best example for primary healing. Secondary healing, uh, great, excuse me. If the wound healing course in the wound is disrupted by infection, dehiscence, hypoxia, or immune dysfunction, secondary healing stage begins. During secondary healing, granulation, tissue formation, and epithelialization over this new tissue take place. This type of wounds are more susceptible to infections and poor healing. A perfect interplay of several cells, growth factors, and cytokines are required for a complete closure of skin during wound healing. Platelets, neutrophils, macrophages, monocytes, fibroblasts, keratinocytes, endothelial cells, and T lymphocytes appear in the wound area and play critical roles during wound healing. They release several growth hormones, cytokines, and other survival or apoptosis in inducing agents, which are key components of wound healing. Pathophysiology. Wound healing has three overlapping phases, which are inflammation, proliferation, and remodeling. Inflammation. This phase includes hemostasis and inflammation, how I told before. An injury to the skin immediately initiates clotting cascades which provide a temporary fibrin blood clot plug to the injury site. Meanwhile, 5 to 10 minute vasoconstriction is triggered in the wounded area. These temporary reactions prevent further bleeding and protect the wound. Moreover, this fibrin plug forms a temporary matrix which serves as a scaffold structure for further healing process, like the migration of leukocytes, keratinocytes, fibroblasts, endothelial cells, and serves as a growth factor resource. Vasodilatation occurs after this brief vasoconstriction response, which will cause local hyperemia and edema. This exposed subendothelial collagen and tissue factor due to injuries stimulate platelet aggregation and activate platelet degranulation. The released hemotactic factors and growth factors complete hemostasis and start inflammation. Inflammation. Um, we start talk about neutrophils. They require to the wounded area within the first 24 hours and stay for 2 to 5 days. They initiate phagocytes, which is continued by macrophages later. These phagocytic cells release reactive oxygen species and proteases for killing local bacteria and debriding necrotic tissues. Neutrophils also act as a chemoattractant for other cells and augment the inflammatory response by releasing many pro-inflammatory cytokines. Macrophage arrives approximately 2 to 3 days after the injury. Similarly, they release numerous growth factors, chemokines, cytokines, which promote cell proliferation and synthesis of extracellular matrix molecules. The following proliferative phase is characterized by granulation tissue formation and vascular network restoration. This phase starts approximately 3 to 10 days after injury and takes days or weeks to complete. Various cytokines and growth factors have a role in the phase, such as transforming growth factor beta family, TGF beta, including TGF beta 1, TGF beta 2, and TGF beta 3, interleukin family, and angiogenesis factors. The predominant proliferating cells are fibroblasts and endothelial cells in this phase. During the cell proliferation, a requirement for an adequate blood supply occurs, therefore an angiogenic response is initiated simultaneously. This response is mainly simulated by local hypoxia, vascular endothelial growth factors, platelet-derived growth factors, fibroblast growth factors basic, and the serine protease thrombin. New vessels are built up by two mechanisms, which are angiogenesis and vasculogenesis. Angiogenesis is a sprouting process in which new vessels grow into the avascular site from resident endothelial cells of the adjacent mature vascular network. However, vasculogenesis is a de novo process in which progenitor stem cells differentiate and form new vessels without sprouting from any mature vascular network. These progenitor stem cells are known as endothelial progenitor cells, which are typically found in the bone marrow. After the injury, EBC recruitment begins into the circulation. Nitric oxide, VEGF, and matrix metalloproteinase, mainly MMP9, have a role in EBC mobilization. Likewise, a stromal-derived factor 1 alpha is the main homing signal to get the EPCs to gather into the areas of ischemia. Finally, a new vascular network is formed which provides nutrient delivery, gas, and metabolic exchange. Anti-angiogenic medications such as bevacizumab may disturb this phase and lead to chronic wound formation. On the other hand, epithelialization also begins after wounding, which is stimulated by inflammatory cytokines and different growth factors. Local keratinocytes that are found at the edge of the wound and epithelial stem cells in the bulbs of the hair follicles and apocrine glands take part in epithelialization. Stem cells differentiate into keratinocytes, and keratinocytes begin to migrate over the wound edge until a physical contact with each other. The contact inhibition from neighboring keratinocytes ends up the migration. The last step of the proliferation phase is the granulation tissue formation. Fibroblasts migrate to the wound site and proliferate within the wound. Then they begin to synthesize a provisional matrix containing collagen type 3, glycosamine glycans, and fibronectin. The granulation tissue is composed of fibroblasts, granulocytes, macrophages, capillaries, and loosely organized collagen bundles. Also, this new classic red tissue is highly vascular because the angiogenesis is not completed yet. Remodeling is the last phase of the wound healing, begins from day 21 and continues up to 1 year. In this phase, there is a precise balance between synthesis and degradation of the new tissue that needs to be strictly preserved. Any disruption ends up with a chronic wound formation. During the remodeling phase, the granulation tissue formation ends and the maturation of the wound begins. ECM components exposed to some sudden modification to form a stronger and organized ECM. Collagen type 3 is replaced by stronger collagen type 1. The tensile strength of the wound gradually increases. The collagen synthesis continues for at least 4 to 5 weeks. However, the collagen in the wounded area will never be as organized as collagen found in the healthy skin. It is important to note that during collagen synthesis, the hydroxylases require oxygen and vitamin C. Thus, hypoxia and vitamin C deficiency can affect wound strength. Matrix remodeling enzymes, particularly MMPs, have significant roles in the remodeling of local matrix. Microenvironment together with cellular migration and proliferation and angiogenic processes. Remaining cells of the previous phases undergo apoptosis. Any disruption in wound healing phases lead to excessive wound healing or chronic wound formation. Excessive wound healing. The pathogenesis of the excessive wound healing is not fully understood. It is an abnormal form of an wound healing which is characterized by a continuous localized inflammation. There are excessive collagen synthesis, abnormal collagen turnover, and exaggerated ACM accumulation in this wound. Keloid and hypertrophic scars are examples of excessive wound healing. And I'd like this picture because there we see a normal skin, we see the fatal wound, we see the oral wound, yeah, and it looks like a fatal wound. But we have myofibroblasts, yeah. Uh, and you see what difference between hypertrophic scar and keloid scar, and how you see in keloid we have more lymphocytes, yeah, and this is the reason why we have this problem. And there we see the more blood vessels, and this is the second reason why keloid is so big. Chronic wound formation. Wound which has failed to heal in 4 weeks is defined as a chronic wound. Sometimes the period shown chronicity cancer masses. Age, immune status, malnutrition, infection, insufficient oxygen and or perfusion, smoking, diseases, medications, radiations, and chemotherapy are the main risk factors that can lead to chronic wound formation. Chronic wounds are usually classified as vascular ulcers, diabetic ulcers, and pressure ulcers. Vascular ulcers we delayed for venous and arterial ulcers. Wound healing has contrasting molecular and clinical characteristics in the fetus and elderly population. The first difference is that inflammation is not clear in fetal wounds. Inflammatory cells in a fetal wound are less than an adult wound. Similarly, interleukin 6, 8, 10, TGF-beta 1, TGF-beta 2, and 3 concentrations in a fetal wound differ from an adult wound. Moreover, ECM content changes in fetal wounds. There is a higher ECM production rate, a higher ratio of type 3, type 1 collagen, and a higher the amount of hyaluronic acid in fetal wounds. Furthermore, myofibroblasts do not exist or very few myofibroblasts exist in fetal wounds. This may explain the scarless wound healing in the fetus. Scarless wound healing ends at approximately 24 weeks of gestation in humans as the skin structure is altering dynamically during pregnancy. On the contrary, wound healing deteriorates in the elderly populations. The total collagen amount in the dermis and the epidermal turnover time decrease during aging. These changes, together with comorbidities, lead to slowly wound healing in the elderly population. As immunosuppressed patients susceptible to infections and have a diminished ability for fighting infections, wound healing is delayed due to an extended inflammatory phase. Anti-inflammatory drugs, particularly in the first 3 days of healing, corticosteroids, immunosuppressants, and chemotherapy agents can alter wound healing. Similarly, some comorbidities have a negative influence on wound healing. Diabetes mellitus is one of the most significant diseases related to chronic wound formation. Poor perfusion, neuropathy, decreased immune function, slower collagen synthesis and accumulation, and inadequate angiogenesis are the leading factors for diabetics to have an increased risk of infection and delayed wound healing. Another critical factor for a normal wound healing is adequate perfusion and oxygenation of the wounded area. Oxygen is a significant element for a successful wound healing. It takes part in inflammation, bactericidal activity, angiogenesis, epithelialization, and collagen deposition. Smoking, peripheral arterial insufficiency, prolonged and unrelieved pressure, and even radiation lead to chronic wounds due to inadequate oxygenation. Radiation causes microvascular obliteration, fibrosis, and alterations in cellular replication, which cause delayed wound healing. Also, chronic venous insufficiency leads to chronic wounds due to ischemia. Venous hypertension results in edema, which disrupts the metabolic diffusion of the tissue. This creates an ischemic environment, and then this tissue reperfused by walking or elevation. This chronic perfusion injury causes inflammatory changes. Inadequate protein and carbohydrate intake and vitamin deficiency can result in delayed wound healing. Fibroblast proliferation, collagen synthesis, angiogenesis, and collagen remodeling are related to protein status. Poor carbohydrate reserves may cause protein catabolism. Vitamin C, thiamine take part in collagen formation and are related to wound strength. Vitamin A has a role in inflammatory process. Zinc is also a significant cofactor for wound healing. For this is all what I want to tell you guys, and I understand that the wound healing is the hard part of your education in the surgery, but remembering that this really needed known in your future. For this we will finish and have a nice day guys. Bye bye.